So our starting point was the data. And we looked at the data. We looked at what we're buying in 4 sectors. And we started this process almost 2 years ago. We looked at inpatient care. We looked at primary and preventive care and ambulatory care. We looked at nursing home care. And we looked at home care. And we looked at 3 things. We looked at the levels of payment. We looked at how we pay. And we looked at what we got. Now, Joe gave you the bottom line of what we got, and I don't think there's anyone in this room who can say we got a good enough return on our investment. There are other ways you could put it, but I think that's a fair way. So let's come back to the level and the method. And we put it all together, and we were pretty appalled at how we have squandered our Medicaid dollars. And whether you're sitting here representing a provider or provider association, or you're sitting in here as a taxpayer, I'm hoping you're going to be appalled as well. So last year we came in, and with the support of the legislature, we reformed how we pay for ambulatory care. We began a process of moving dollars from inpatient to outpatient care, and we're going to continue that this year as we put forward reforms on how we pay for inpatient care, for nursing home care, and for home care. Our hospital CEOs, some of our best hospital CEOs cannot explain to you how we pay for inpatient care in any detail because it is incomprehensible. If it's not transparent, we don't know what we're buying. We need to know what we're buying, and you need to know. You're the taxpayers. You're giving us the money to do it. You need to know what we're buying. What we want to buy is in the next 3 bullets, and we want to buy that care consistent with the healthcare policy priorities and planning priorities that the Commissioner outlined. We have to be able to update our rates regularly. We have to pay for Medicaid patients. Medicaid's job is not to cover underpayments by other providers. Medicaid's job is to pay for care for Medicaid patients. We have to comply with federal Medicaid rules. As we've all noted, we hope we have a better partner in Washington going forward, and that's a big issue. And then, of course, we can only buy care to the extent the state budget has the dollars for us. So, against those principles, we looked at our current Medicaid rates. And we've begun to reform ambulatory care last year. This year, we're looking at nursing home, hospital, and home care. What do we find? Our current methodologies are opaque and they're complicated. They're so complicated that they are generating more appeals than we can manage. I get repeated emails from the representative of one nursing home. Could we please get the 12 appeals they have pending out? 12 appeals, one nursing home. We have 600 nursing homes and more than 6,000 pending appeals. What kind of system is it that generates 6,000 appeals? It's obviously a system we need to re-examine. It's so complicated, we can't get rates out on time. That's outrageous. So hospitals and health and nursing homes and health plans, they start the year not knowing what their rates are. We're happy if they know their rates midway into the year. And remember, sometimes the delay isn't ours because all of our rates have to be approved by Washington, and that can add literally years of delay. Clearly a system that is broken. Our current rates are based on costs from the 1980s, except in nursing homes where they can choose the wage factor they want to use, and our law actually says you can choose nursing home 1983, 1987, 1993, or 2001, whichever one you find most advantageous. How did we get there? Because every time we updated the wage equalization factor, I keep looking at Wendy, who's finally got me to understand this. If I blow it, don't tell me. Every time we updated our wage base, we said to nursing homes, but we'll hold you harmless if a previous year was better. Now, does that make sense? And if you really didn't like any of the 4, and if you're proprietary, you've got another option, just sell it to your brother, your sister, or your mother, because that generates another base year. That's what we've done, folks. And you can't blame providers. I made a good living before I came into government telling providers how to exploit the system we put out there. Doesn't make a lot of sense. And it's certainly not, it doesn't incentivize efficiency, and it's not tied to quality. So, our new rates. Well, first of all, they're going to be transparent. So everyone in this room will understand how we pay. You will not have to hire 7,000 consultants and spend years trying to understand it. They will be transparent. They'll be based on the cost of serving Medicaid patients, not on the cost of serving Medicare patients or commercial patients. They will be based on the cost of serving Medicaid patients, because if we don't make it based on those costs, and we don't, on the cost of patients for whom we are responsible, and if we don't make the reimbursement methodology transparent, it isn't going to be accountable, because I can't account for what Aetna and Oxford is doing, any more than they should have to account for what I'm doing. One of the things that we're moving away from is institution-specific base years. In every one of our systems, we set base years based on what that particular hospital, nursing home, or home care agency's costs show. Well, you know, you don't have to be a genius to figure this system out. More costs, more money. Doesn't, you know, we don't buy quality, we don't buy efficiency with institution-specific cost basis. And then we want a system that incentivizes efficiency and rewards quality. And as the commissioner talked about, as we move to a new system, we need to provide some transition funding to allow our providers to change their operations and bring their costs in line with the revenue available. Not a hold harmless, not a 10-year transition, but a reasonable transition to permit well-run providers to move their operations consistent with the state's healthcare priorities and the dollars available. So this slide looks at the new inpatient rate methodology that we're working on. And I'm not in a position to do the same slide for nursing homes and home care, because this one is public as a result of the work we've been doing all summer. So I'm using this, but the principles I'm talking about here work equally well in nursing homes and home care. We start with a statewide base. Our base cost will be a statewide base, not a hospital-specific, not even a regional-specific, because for hospitals, it makes sense to take a statewide base. Now, there are legitimate differences among institutions. We have academic medical centers in New York City. We have small community hospitals in the Adirondacks. So there are legitimate differences that need to be recognized. And we need to recognize them in a meaningful way. How do we do that? We start with a statewide operating base rate. We adjust it for institution-specific wage differences. We debated, should we use regional wage differences or institution-specific? And because in the hospital world, even within a region, there are such dramatic differences between an academic medical center and a community hospital, that we really concluded that it was appropriate to use institution-specific wage differences and regional differences for energy costs. So we're proposing what are called APR DRGs, which is basically, we need to rate the payment based on the acuity level of the patient. Right now, we do it with 2 acuity levels, or 2 risk adjustment levels, and we're going to move to 4. Again, we are reflecting in the first box the differences among our institutions, and in the next box are differences among patients. The next box is GME, and that is an add-on to rates, again, reflecting we have academic medical centers, we have teaching hospitals, and we have different costs based on their differences in the number of residents and their teaching obligations. We do pay for GME now, but we pay for it based on a 1988 Medicare formula. That's for indirect. 1988 Medicare formula, which Medicare has abandoned. Medicare abandoned it, we're still using it.